So we are going to take another gram-positive streptococci today, and I'm going to again start with the case study, and I'm going to talk about impact slides, so it will be easier for you to remember, I hope. So you can see from here, many times when you are in ER, you look at a patient, and for example, in this case, what you're looking at is just a puncture wound. You can see a puncture wound over here, and some of these puncture wounds are just oozing blood. So that's what you normally see, and make you wonder how much is the damage done. Because the whole idea is, since I'm teaching you microbiology, as a rule, you just need a hole. You just need one tiny little puncture, and there you go. The microorganisms are going to go and cause damage. So that's important message for you, is that don't ignore slightest of injury, and don't ignore even a pin prick. And you can see in this case, the physician just looks at it. It's a little bit swollen over here, but 2 puncture marks in this case. Let me see if I can make it any better. I don't know. Always a glitch here, and I don't want to get stuck with that. Let me see if I can do it any better. Maybe this is the best. Okay, anyway, you got the notes as well. Another important thing for some of the injuries, especially for those common bacteria that are part of your skin. Remember, we're talking about these commensals, so they are part of your skin, and you can see they're beginning to cause damage. In this, you can see redness, swelling, and the erythema on the lower leg. Now, I'm going to let you read the case if you haven't done so far. And meanwhile, I'll play with it. How can I expand that, if I could? A little bit better. Not better. To move back to the lecture assistant, call the out. Okay, I think I'll leave it here because I'm waste time. You can see from here now. Remember the age of the patient, the sex of the patient, the injury of the patient. These are prototype classical cases, and each one of them is for a purpose. So in this case, you can see a 46-year-old man scratch. Remember, I just gave him a scratch on his leg by his German Shepherd dog. And then he doesn't notice that, he doesn't care, goes to work, and next day he has a low-grade fever, chills, backache, and myalgia. So he goes to the local emergency department, and you see the kind of minimal erythema I showed you in the first line, very small redness. But it is oozing. We call it oozing, thin serous discharge. And they do a culture of that, and they have to start intravenous antibiotics. That's serious for infection. Within 10 hours, so you can see some of the bacteria are so nasty, it just take a couple of hours, and if you are late, you lose the time. Within 10 hours, the patient becomes confused and hypotensive. And then he's transferred to ICU. They see that erythema, and they see the local spread of the wound, and then gradually multiple bullae, that kind of swellings appear. And at the same time, they take him to surgery, then they see yellowish fluid coming out from the muscle tissue. They do something, as I said earlier, it's called debridement. And then they look at the culture, and they grew, of course, streptococci in there, debridement, right? And the patient continues to decline. He develops organ failure, liver failure, renal failure, pulmonary failure, cardiac failure, till he dies in 3 days. You can imagine, you just start from scratch from your pet dog, and all you need is a couple of streptococci go into the system, and you can see we are going against the time. So if you, I mean, this was the best scenario. He was put on antibiotics, but nothing worked. Okay, so that's a typical case of infection that you may get from streptococci. This particular condition that you saw, it may have been ignored earlier, just like a scratch on his leg, unnoticed, a little bit of oozing over here. But what was developing inside was infection. We call it necrotizing fasciitis. So if you remember a little bit of anatomy of the leg, there is on the posterior side, there's soleus muscle, there's gastrocnemius muscle. You know, there are different layers, and they all have a fascia there. So each layer is protected. But this, in case the toxins released, the bacterial leaves are so fastly acting, they're going to penetrate and go deeper and deeper and deeper. As I give you an example the other day. Now, in this case, you open the wound up, you have to clean everything up. You have to make sure that the muscles are not infected. So you can see they really open him out, because if they don't do that, they're going to lose him anyway. So this is a necrotizing fasciitis to such an extent they have to cut all the tissues, because you cannot leave dead tissue there. So the choice is, in this case, is to save the patient or save the leg. So they would rather save the patient and not the leg. But they start off with doing their best. So any small streptococci that goes into you, they keep on cutting this tissue, cutting, till they go to the bone. And sometimes they have to amputate that. So anyway, so you can imagine the damage the infection from streptococci can cause. As a genus, a bigger streptococci, which has many different types, it's a gram-positive. It comes in pairs or chains. It's facultative anaerobes, right? And the nutrition requirements are complex, and it needs to grow on blood or serum or enriched media. That's why it goes and look for the muscles and so on and so forth. Generally, these bacteria have the capability to get their food from carbohydrates, and they produce lactic acid. But the most important thing, if I was to ask you how would you differentiate between staphylococcus and streptococcus, the answer is this one is catalase negative. The previous one was catalase positive. If you look under a microscope like a gram staining, which quite a few were struggling the other day, so you can see this is how the gram staining looks like, especially if you were to grow a chain-like structure. Streptococcus, I mean, like a chain-like structure that you see in this case. Now, we classify streptococci into different types based upon serology. For example, what kind of antigen do they carry? Based upon the hemolysis, that how do they lyse the red blood cell, and what are their biochemical and physiological properties. Now, this was developed by Professor Lansfield regionally from A to W, depending upon the antigen. So we have a streptococci A, B, C, D till W. So you can see different types of cocci. Then, depending upon, remember I told you about hemolysis in the streptococci, and I said it's a beta hemolysis. But I said I'm going to come back to you and explain to you what are the difference. So there are three different types of hemolysis. One is a beta, alpha, and gamma. So beta means complete hemolysis of red blood cells, whereas alpha means incomplete, and then gamma is no hemolysis. So group A and B are coming into complete hemolysis. So if they were to infect blood, they will chew up all the red blood cells. That's what it means. You can imagine you'll have very important anemia because your red blood will be taken up by this bacteria. Whereas if it's group D, so if I was to ask you which one of this is the most less lethal or less pathogenic, the answer is D, because it doesn't cause hemolysis. Okay, but then again, there are biochemical properties that we're going to discuss in a while. So let's begin with the first one. Let me play with it again if I could. No, it's not my day today. I'm messing up with technology. The more I try to fix it, the more problem I get. Okay. All right. So let me do like this if it allows me to do it. No, it doesn't. All right, I'm going to touch it now. All right, so let's start with group A. How many of you have heard of strep throat? Strep throat. So that you're talking about strep throat right now. You can imagine that the case that was extreme form. Why do we care? It's a serious thing. Strep throat is a serious thing. Okay. Now, it's a very rapidly growing gram-positive cocci, and it is called A because it has a carbohydrate antigen A, and it's a type-specific protein which is called M protein. And if you remember your earlier lecture, M protein was considered an adhesive protein. That was the protein that's going to anchor to the epithelium of the throat. It's called M protein. As far as their virulence is concerned, why is it so damaging? Why is it so pathogenic? The reason is because it avoids phagocytosis. Okay, it has a capsule, so it is going to be those specific proteins on the capsules which are either M. It also releases a enzyme to chew up C5a. So you can see it as a C5a peptidase. So if you throw C5a at it, it's going to chew it up. So avoid phagocytosis. It will adhere and invade host cell that you saw in the muscle and you normally see in the throat. That's because of M protein specific for this one, and lipotecoic acid and F protein. Lipotecoic acid is a common, that kind of structure that I told you, string-like structure that goes from the cell membrane, passes through the peptidoglycan, and hangs out like thread. So that's a lipotecoic acid. It does produce toxins, and it produces a lot of toxins. That's why, the poor gentleman, 46 of age, died within 10 hours because of the toxins. And remember, even we started antibiotic therapy, IV didn't help. So we have to do more. That's what the question, you have to do more when it comes to that kind of infection. It produces tons of toxin. The most important toxins are, as you can see, are those toxins which are pyrogenic, meaning they cause fever. They call those toxins which cause fever are called pyrogen because pyrexia is fever. The most important is streptolysin S, streptolysin O, streptokinase, and DNase. So you can see it comes up with a lot of damaging enzymes that are released. Now, it also causes pus. It causes suppurative. It's usually difficult to separate staph and streptococcus just based upon pus-forming disease, but it does have a pharyngitis, strep throat, soft tissue infection you saw in the case, streptococcal toxic shock syndrome, right? And then again, the most important thing which we did not talk about in the staphylococci, and I'm going to talk about in this one, is that it has an ability to cause a very important disease which we call a rheumatic fever and glomerulonephritis. Now, you can see if you were to go on agar, is from large colonies, and this is beta hemolytic as compared to group B, right? It's a group A and group B. The other name for the group A is we also call it streptococci pyogenes. There's another name for that because sometimes it comes with one or two more names. And in this one, streptococci A galactiae, which is group B. This is also very important. I'm going to discuss today. It has small colony, large colony with small zone of hemolysis, really small as compared to this one, which is large. So if you were to grow them on agar plate, just by looking what the colony format is, we can pretty much determine whether it's a pyogenes or it is a galactiae. Now, as far as pathogenesis is concerned, people, if you have a sore throat, you're coughing up, so you can cough up, and it's going to go and cause sore throat, right? And when it goes over here, it can go to the blood, right? And then cause a lot of toxins to be released. So there are many different toxins which are released. You can also get it most of the time by direct injury, as you saw in the case, right? And then you get cellulitis, and then all other diseases that even you saw in impetigo, carbuncle, pustule as well. But most of the time, the primary source of infection is we call respiratory droplets. You cough up, you speak up, you throw your bacteria on other people. That's what it is in terms of the primary source of respiratory droplet or direct contact with the skin. And the rest pretty much is the same. Group A streptococci, which I just said is also called streptococci pyogenes. There's a acronym for that we call GAS, G-A-S, Group A streptococci. You can see over here, Group A streptococci disease. Okay, now this is the important thing for pathogenesis that I want you to remember. And these are, remember we talked about journal virulence factor. Now we want to have a very specific virulence factor. Again, this is going to go in terms of drug development. It's going to go in terms of the therapy we may have in future other than antibiotics, okay? Because antibiotics at the best are going to lyse the cell wall, but what good that would be if they're going to release toxins. So you can see from here, this is cell membrane. You're pretty familiar with that, right? And the most important thing this bacteria has, these are the proteins, which are called M proteins. They go all the way from the cytoplasm, all the way hanging outside. And these are those things that it latches onto the structures. Then it has an F protein, right? And then it has those toxins as a part of the cell wall. You can see septolysin S, C5a peptidase, right? And some of the other important aspects. But the most important thing for this one is the capsule. You can see the capsule over here has hyaluronic acid. So that's another hyaluronic acid capsule, right? And then the other important thing for this one is that it secretes those exotoxins. Remember that these toxins are produced by the bacteria and they are released out. So in this case, you can see from here, they're made in the cytoplasm, and these are those important enzymes and toxins which are excreted as compared to those enzymes or toxins that are a part of the cell wall. So there are two different aspects of the structural element. For example, sometimes we don't want to lyse a bacteria, because if you lyse a bacteria or kill the bacteria, it causes more damage other than normal damage they would cause. The reason is because all those toxins will be now released. So they were there in one site, and you break them apart, and it scatters out. You don't want that, okay? So this is a typical situation where we have peptidoglycan layer, as you can see from here, and we have a cell wall, and we have all those important proteinous elements and all those toxins for streptococci or pyogenes. The other name for that is gas. Now, if you go for the antigenic structure of group A, that's what we look at over here. Again, the same thing, cell membrane, cell wall, and these are the epithelial cells of the throat that this wants to attach to cause strep throat. So you can see what we see over here is that these are those surface fibronectin proteins present on your cells, and we have F protein and M protein which basically latch onto that. So you get sore throat, and you say, I'm gonna take lozenges, I'm gonna have salt water, gargle, so on and so forth. But they're so firmly attached over here, you cannot detach them unless you come up with a plan. Okay, because they have these structures. You can see from here, F protein and M protein, they latch onto that. Okay, so in order for you to stop this bacteria from attaching to the epithelium which is concerned, you have to block that. Does that make sense? So something expressed on the cell, fibronectin, and something expressed onto the bacteria. I gave you an example for two at least, M protein, F protein, and some of the pili also will go and give an additional support to get attached. Now, I'm not going to go and teach you the detail of the drugs that we have, but I'm just giving an idea, preparing you for a future drug design and delivery, that M protein is a dangerous stuff. So we want to work on those M protein. We want to come up with something that we want to block that M protein so that attachment doesn't take place, so that we don't have that damage, right? Now, if you go for the structure element of those M proteins, you will see that they have some of the portions which are conserved portion, and these are the ones that are rooted into the cell wall. Remember when we talked about super antigen, super Ig family, I told you one of the things that you want to do is that make sure that their legs are attached. So you can see, based upon those conserved regions of amino acids, we can see type 1, type 2, type 3, and type 4, right? And all 4 types have epitopes. You can see the epitopes over here, 1, 2, 3, 4. They may stimulate an immune reaction. And the most important thing that you have to understand, I'm going to ask you is, especially for streptococci, is that they stimulate an immune reaction, which is a cross-reactive immune reaction. And that cross-reactivity will cause rheumatic fever. So that's the basis of understanding that once a person has rheumatic heart disease, the very first question we ask those patients is that, did you ever have sore throat or strep throat in the past? So your body makes an antibody, and since we know that M protein is important, and there are 1, 2, 3, 4 conserved regions, so there are 4 different types of antibodies. One of these antibodies would not only recognize that particular F protein or M protein, it will also go and attach to your valves of the heart. Right? There's a cross-reactivity and cause damage to the valves of the heart if you are not careful, if you don't treat it properly. Okay, so you can again see a EM picture of M protein in this case. You can see from here the structure elements. These are epithelial cells. E is an epithelial cell, and you can see all those, because in the cartoon you just probably saw one F protein or M protein hanging out, so you thought maybe there's only one. But in reality, if you look at under the electron micrograph, you will see it's like a hairy structure. You see all these hairy structures? Tons of them, which are either M protein or lipotecoic acid, and they also are attached to the pili that it has. It goes and latches onto the surface of epithelium. Let it be epithelium of the heart, let it be the epithelium of the throat, but you can see for sure that that's a real attachment that we normally see. I just want you to give you an idea that all the cartoons and picture that we show you just for the concept forming doesn't really mean that there will be only 2 F protein, 2 pili, but the fact is on one bacteria you have hundreds and thousands of so-called M proteins. Okay, now if you look at the toxins that these bacteria release, for example, one of the toxins bacteria releases is streptolysin O. So you can see that this streptolysin O, like alpha toxin that we talk about, the Staph aureus, also has an ability to poke a hole or pore formation into the cell. It's going to go and add all those enzymes that this bacteria has, like streptokinase, C5a peptidase, hyaluronidase, all those things that are going to dismantle the structure element of the cell. That's what you call tissue damage. That's why you see all those tissues being removed, because of these toxins which are there, and they have an ability to form a pore. Not only that, but they have an ability to even to kind of resist phagocytosis. So you can see from here, neutrophils will come and they would not be phagocytosed because bacteria tend. So that's like, for example, it's just like if one bacteria and neutrophil comes and want to phagocytosis, so they will hang on, put their hand for 3, 4 more bacteria, form a chain. So then neutrophil has to struggle because they're all together. Okay, and that's what there is a factor we call, what keeps them together and stops them from being phagocytosis. There is a factor we call factor H binding. All these factors are important because we want to separate them and let our neutrophils to take care of them. Okay, so we talked about virulence. I told you about that. And the whole idea again is that they have an ability to avoid oxidation. They have the ability to attach to the surface. They need to invade and produce. So that's pretty much standard. And if I was to ask you what specifically is there for staph or strep pyogenes that it avoids opsonization and phagocytosis. So for opsonization, you need complement. If this bacteria releases a C5a peptidase, right? So of course, it's going to avoid the complement. If there's no complement, there's no opsonization. And the other important thing is that the capsule for this particular bacteria has a high uronic acid capsule, which is pure immunogen and interferes with phagocytosis, right? And then I told you earlier about the conserved region M protein that binds to beta globulin factor H. So there are three complement pathways, right? So we have a complement pathway, which is a classical pathway. There's a complicated pathway we call alternative pathway. There is a third pathway, which is a mannose binding pathway. So unless and until these pathways are activated, opsonization will not take place. And antibody-dependent cell-mediated cytotoxicity will not take place. So they would avoid that because they have this M protein. They bind to one of the regulatory factors. If you remember, I said there are three regulatory factors I want you to know for the complement that regulate the complement cascade. So they bind to one of them and would not allow the complement regulation. That again is important for pathogenesis. Let's talk about M and F protein a little bit in detail. So these are basically, you saw those things jutting out. They are proteins invade into epithelial cell, and they think that this is the reason that we have persistent infection, especially strep throat. That's the reason, right, as we think today, that why do we get strep throat? Because of the M and F protein, pretty much it. Then there are toxins, which are called pyrogenic toxins. And as I said, these are those toxins that cause fever. Now, I'll put some of the information over here for you to remember, but you can make your own notes as we move along, because I may say the same thing in different bacteria. So it's your task to put them together. Now, for example, I will say the toxin produced by streptococcus pyogenes, is it similar to, I'll give you a bunch of bacteria, but the answer is that the toxin it produces is similar to Corynebacterium diphtheria. And you know what the reason is? Because Corynebacterium diphtheria cause diphtheria. So diphtheria is also infection of the throat. So both of them have the same toxin going to the, we call whooping cough. That's like pertussis. So these are all together because they have the same toxin and we deal with them in a similar way. Let's talk about some of the toxins that it has. Toxin 1 is oxygen stable, non-immunogenic, and this can bind, and this toxin is going to go and kill our erythrocytes, leukocytes, and platelets. But this is oxygen stable. Okay. The other toxin, which is streptolysin O, is oxygen labile, so it's not stable, right? It's gonna, but again, it also has capability of lysing all these cells, right? And this particular toxin, which is streptolysin O, is antigenically similar to other oxygen labile toxins. So the question in this case is, tell me the name of the bacteria that share the same oxygen labile toxin. Right? So in this case, you can see the previous one was non-labile, but this case is oxygen labile. So we have streptococcus pneumoniae, which is one of the, I'm going to come to that, I'll come to it in a while. Clostridium tetani, Bacillus cereus, Listeria monocytes, 1, 2, 3, 4. So 4 bacteria have a same O. The O basically you can remember like a mnemonic for oxygen labile, okay? And why do we need to know that? The reason is if I was to test you, you have a sore throat. I want to test if it's because of streptococcus. I want to do a serology. So what I would do is I will take the sample from your throat and add the antibody to this streptococcus. That's an O. So if it matches with antibody, I'll say positive. That makes sense? So that's the whole idea, because the antibodies are readily formed against O. We call ASO antibodies. Or if you come with rheumatic heart disease, and I ask you, did you ever have strep throat in the past? And you say, I don't remember. So, okay, fair enough. I'm going to run your blood for ASO titer. And guess what? If you have this antibody in the system, you had strep throat in the past. So that's what the importance of all these tests that we have, especially when we develop serology for these cases. Streptokinase, again, this is an enzyme produced by the bacteria, and you will amazed to know that we learn from bacteria. It's bad for bacteria. It's good for bacteria. It's bad for us when we get infected, but it's good for us because the moment a person gets myocardial infarction, the very first shot we give to that person is streptokinase. And guess what? We got it from this bacteria. Why? Because we know that this streptokinase is going to lyse blood clot, because we don't want blood clot to develop, right? So it is good for bacteria because that's why if it releases that enzyme, so it kills the person within 10 hours. The reason is because it's going to facilitate the rapid spread of this, because it is going, normally what happens is that you have a blood clot, so everything is contained, like a granuloma formation that when I told you for hypersensitivity reaction, a granuloma is formed so that you can contain the bacteria and bacteria doesn't go out. So if you release streptokinin, or streptokinase is going to facilitate the spread by breaking the clot. Okay, so you can see from here. And then again, you can also look for antibodies, which is a very useful marker for infection, which we call anti-streptokinase antibodies. It has an ability to go after our DNA. So you can see DNases are there, go and kill the cell. This is one of those mechanisms we have. We talked about C5a peptidase and many other enzymes, because if you remember, the component C5a mediates inflammation. This was something when I taught you complement, I saw it's important to cause inflammation, though inflammation is bad, but we need to have that much amount of inflammation to bring phagocytic cell and opsonize the bacteria. So if this bacteria releases a peptidase, it's going to chew this up and then spread, allow the bacteria to spread. So if you see, one of the most important things, which is very obvious from the case study, the spreading power of this bacteria, it spreads very fast. Okay, epidemiology, you can see from here, mostly we do not have it at all times, but there is something we call transient colonization. This means that other than the normal flora, where you have permanent colonization, you may at times have a transient colonization. So they'll come and establish a colony for a limited period of time. And during those times, right, you may get infected because you just had a contact and your body's still struggling with that. So you may get a sore throat, and then again, it's going to spread and cause problem. Respiratory droplet, people are at very high risk. So these people are at very high risk. Again, we talked about that many times. Those people who have chronic diseases, those people who are in the hospital, those people who are young, especially the kids in the school, and they will pick up, if you dial the school attendance line, they say if your child is sick and has flu-like syndromes, keep him home. That's the whole idea. We don't want to spread it to the rest of the people. So that's pretty much for this case. How do you diagnose? Typical, you do a microscopy. You can do a direct test. I just gave you example for the group A antigen. And there are some other tests that we talked about. This is catalase negative. And then again, you can do a anti-streptolysin O test, ASO test, especially if you have heart disease or if you have a kidney disease following streptococcal infection. Remember, this was cross-reactivity, which was not present for Staph aureus. This is present for strep. That's why we worry more about strep throat than anything else, because that's going to lead to kidney disease and heart disease. Okay, we already discussed that. Let's skip that. How do you prevent? Penicillin, again, is a drug of choice. As I said earlier, people may carry it in their oropharynx for a long time. And then you want to make sure that you keep the therapy for at least 10 days so you can prevent the rheumatic fever in future. You want to make sure that you kill all the bacteria so that you don't have rheumatic fever. And anybody with a history of rheumatic fever, I've been talking about, if you go to dentist, is going to ask you the same, because dentists are worried about valvular heart disease, especially rheumatic fever. So what they would do is that before they start working on you, they would give you prophylactic antibiotics. Want to make sure that you don't get this cross-reactivity. Okay, so streptococcus A galactea, which is a group A, we talked about group B. A was the strep throat. Don't confuse that with this one. This B is also important. And how would you differentiate between streptococcus A galactea from streptococcus pyogenes? The test is, this one is resistance to bacitracin. That's the answer for that. The other problem with this one is that transplacental transmission or delivery. So that's a danger. Because remember, as we talked about the vaginal flora, and I said that it varies from person to person, it varies from age to age, it varies with your hormone, it varies about whatever techniques of hygiene you're using or sanitation you're using. But 10 to 30% of pregnant women may have their normal flora as streptococcus A galactea. So if the baby is delivered vaginally, they may get infected because of the infected vaginal canal, right? So that's what you see A galactea in terms of the problems to the newborn. And you can see from here, again, group B can go by the, especially for the kids if they're born vaginally, they will inhale it in the respiratory tract from the mother's vaginal canal, and then they may have pneumonia, pneumococcal pneumonia, or they may have meningitis. So that's a serious thing. Or many times you can see from here, normally 10 to 30% as a normal vaginal flora. And then again, it can go and infect to the babies, especially for pregnant women. So that is a typical vaginal colonization during pregnancy that we worry about, especially for group B streptococci. So that's the significance of A galactea. This is an immunological test. So what it tells you, you can see from here, there is no hemolysis, and there is hemolysis over here because this produces a very important a lysine that's going to lyse. Don't worry about that, but it's called CAMP reaction, very commonly done in the clinic. And the idea is that streptococci B, especially A galactea, produce sphingomyelinase C. That is basically the reason why this can go and cross your brain and cause meningitis. So you have to be careful. You want to make sure that we do take vaginal swab from the pregnant women in case they happen to be within those 10 to 30% of women, they have that as a normal flora, and that can be passed to the babies, and babies get meningitis. So that's a serious thing for us to do. I think people, when they talk of pneumonia, they talk of streptococcus pneumoniae, but that is a special strain than the other two strains. So streptococcus pneumoniae is again a beta hemolytic streptococci. Pretty much the same. The only thing is that if you were to look them under microscope, they usually come in the pair diplococci. They also have surface protein adhesions. they have one important thing that they have is that they have a liking for the pneumocytes, which are the cells of the lungs, because they have a enzyme which is called pneumolysin. You can see pneumolysin, right? They also have an IgA protease, because IgA lines the pneumolysin for protective. They kill the antibody, so they tend to cause pneumonia because of this particular enzyme. They also have other local inflammatory response things that are common. They have a polysaccharide capsule, but the most important thing for streptococcus pneumonia again is they cause pneumonia, sinusitis, otitis media, middle ear infection, meningitis, and bacteremia. So you can see that this particular bacteria is more into the internal organ as compared to the tissue injury and skin injury we saw with streptococcus pyogenes. That's why we call that as pus-forming bacteria as compared. So your challenge will be, and you can start working on that. I think there are good tables over here. Put all these 4 or 5 stains of streptococci and make sure you understand them differently. What is the difference between A, B, C, and D, right? And what are the diseases? Because that's mostly the question will be coming from, okay? Now, this is an electron micrograph of streptococci, the chain-like over here, and streptopneumoniae, which is more like a spindle-shaped or club-shaped, as compared to the chain formation, we call it diplococci. So if I was to ask you, name a diplococci, the answer is streptococcus pneumoniae. They come in pairs, classical sign, if you were to take a sputum sample from a patient and look under the microscope. As you can see, gram staining, you see over here, pairs, pairs, pairs. So they had this unique ability to be present in secretions, in sputum, in different areas in a diplococci. The two spherical as compared to streptococci, right, over here, which is like very long chain. But again, it's not a very specific test, but it is a test. So you can see pneumonia over here, lower left, we call lobular pneumonia over here. Whole lobule is gone for pneumonia, and that's a typical for streptococcus pneumonia. The other important thing for streptococcus pneumonia is that they also give a very characteristic erythematous rash. So if a person comes to you and has a rash, you will see that as a very common side effect of quite a few drugs, right? Now, your challenge is that if you look at, for example, this case, the tongue, and look at this, we call it petechial. We call it petechial, very, very small dart-like structures which appear like reddish thing. We call a skin associated, and that basically is the basis of scarlet fever. It's called scarlet fever because it kind of appears like this structure. So we call scarlet fever, and it is pathogenic as well. Then again, rest of the stuff, because of their ability to cause skin damage, impetigo, we talked about that in staph. We talked about streptococcus erysipelas, that is very nasty for this women. You can see group A streptococci cellulitis. So you can see why do we need to look at those F proteins and M proteins and fibrinogen binding proteins, because the antibiotics are failing if you were to treat this kind of a situation where there is an extensive skin damage. And that again, in this case, the streptococci decide to attack the skin cell as compared to the cells of the throat, back of the throat. So that's kind of a difference between these two. Now, as far as epidemiology is concerned, you can see again, most infections, they are coming from endogenous spread. What does that mean? Sorry? Yeah. So what it means is that you already have your nose and throat colonized for it. So you give opportunity for these bacteria to go into you. So that's the challenge that we have as compared to exogenous, right? So most of the infection is endogenous. So what will happen is that it will go from your nose and go into your lungs, sinuses, ear, blood, and meninges, right? Or you can cough out the reason is you have this droplet infection person to person. The colonization is highest in young children. And then again, those people who have a pulmonary disease, because remember, one of the things that I think we must have taught you in physio is that if the bacteria wants to go into respiratory tract, there's a ciliary motion. It's going to push the mucus outside, so you can push all the dirt outside. So one of the things that you may want to do is that you may not want to do is if you smoke, so that ciliary action is lost. So you give chance to the bacteria to come and stay with yourself for a longer time and cause problems, right? Or you're asthmatic or you have chronic pulmonary disease. So all these things give an opportunity to this bacteria to come and attach and then cause problem. Children and elderly are greater risk of meningitis, right? In some of the countries you travel, it's mandatory for you to be vaccinated for pneumococcal vaccine. It's mandatory. If you see the State Department, they will not allow you to travel to this country because of the risk of meningitis, especially for children and elderly, but everybody has to be vaccinated for that. People who have hematological disorder like cancer or any other thing, they already have spleen being removed. They also struggle with it because of the capsule. So if you remove the spleen, you are going to struggle with capsulated bacteria, so you have to make sure that you're given those things. There is also ubiquitous, means present everywhere around the year, but it's more common in cold months. You see more people having strep throat there. How do you diagnose it? Again, you see that pretty much the same. If you put in your mind, it's going to be microscopy, it's going to be culture, it's going to be serology. These are the foundation of bacterial infection in terms of diagnosis. And you can see they have a very important, bacteria has a capsule, right? And we have a polyvalent anti-capsular antibody. So we take the bacteria, mix it with these polyvalent so the bacteria seem under the microscope to be swollen. We call that Colang reaction. So that's a very common test done only for this bacteria. We can also look for the antigen for pneumococcal C polysaccharide, especially in meningitis patient. And we can also look for nucleic acid-based other tests. If you need to culture, you have to culture them on the blood and also know that they are catalyst negative. And we talked about bacitracin, which is a drug for A. galactea. And the drug to be given over here will be optocin. And then again, they are susceptible to optocin. And then they are very soluble in bile. So these are some other tests. If needed, we can always do that. How do we control? Again, you can see it's a gram-positive bacteria. We have a thick polysaccharide peptidoglycan layer. We always use penicillin. But if a person is allergic to penicillin, we can, or you have a strain which is penicillin resistant, we can go for fluoroquinolones or vancomycin. And as I said earlier, mandatory immunization with 7-valent conjugated vaccine. What does that mean? What does 7-valent conjugated vaccine mean? You all are preparing for, and last chapter is included. Many of you are asking me, is it included? Is it included? Unit 2, look at the syllabus. It has all the chapters from 12 to the last chapter. What is a 7-valent conjugated vaccine? Yeah, Ben. You gonna Google it? Okay. Common sense. That's something I told you at that time. Ask the question one more time. Dissect it. Okay. What is 7-valent conjugated vaccine? Don't tell me it's a vaccine. It's a vaccine. Remember, when I told you, the thing is this, that you have 7 different parts of the capsule that you are targeting in terms of a vaccine as compared to one. It's so specificity of the vaccine. It's just like, I'm going to hold something with one finger, I'm going to hold with 7 of these. So you can see strong hold in terms of treatment-wise, in terms of the valency of that particular capsule that is over there, okay? But if you pay attention, what we do is that children can make do with 7-valent, but if we go for adults, we have 23-valent polysaccharide vaccine. So you can imagine the challenge that we have. In order for us to have a very effective vaccine, we are picking 23 different areas over there and targeting them. And remember when I taught you that, I said, if the best vaccine will, if there was only one strain and one thing. Okay. So it's complicated. So this means capsule is very complicated. We are still struggling for that. So we have a 7-valent for children younger than 2, and we have 23-valent polysaccharide vaccine in terms of adults. What I want you to do, I usually give this exercise, and you can do it on your own as well, because things look very simple and straight when you teach you one bacteria. You get to know that, I know that. But when things get complicated, when one bacteria has 4 different strains, and things get more complicated if you have to compare those 4 with the one that we taught you yesterday, or it's going to come tomorrow. So you may want to develop your own charts in terms of those 5 objectives, in terms of physiology, in terms of treatment, in terms of what is the, because by the end of the day, I'm pretty sure they're going to teach you, we call differential diagnosis, right? All look alike. Everything looks alike. But it's your task to know how are you going to differentiate between a meningitis from streptococcus meningitis as compared to any other meningitis. You want to make sure that you run it, because you have to give and treat separately. We're very specific in terms of treatment. So I would recommend that you make your own charts and compare especially group A streptococci with group B streptococci. And then again, make sure that you also know the difference between staph and streptococci and streptococci. These are the commonest bacteria that we come across in the clinical practice. So we really have to have a very strong control on that. Okay? Any questions related